Bismillah ar-Rahman ar-Rahim. Breathlessness. Clinical assessment and the causes of breathlessness. First, the physiological mechanisms of breathlessness. The dyspnea refers to the abnormal and uncomfortable awareness of breathing. It is physiological. Its physiological mechanisms are poorly understood, and the possible afferent sources for the sensation include receptors in the respiratory muscles, juxtacapillary receptors, and chemoreceptors. The clinical assessment. All patients need full history and examination, and the key points in the assessment are the duration and onset of breathlessness, group the causes of breathlessness by speed of onset, although in practice some variability and overlap exist. Patients often underestimate the duration of symptoms. Inquiring about exercise tolerance over a period of time is a useful way of assessing duration and progression. Severity of breathlessness. Assess the level of handicap and disability by asking about effects on lifestyle, work, and daily activities. Exacerbating factors. Ask about rest and exertion, nocturnal symptoms, and the body position. The timing of nocturnal breathlessness may provide clues to the likely cause. Left ventricular failure causes breathlessness after a few hours of sleep and resolves after about 45 minutes. Asthma tends to occur later in the night. Laryngeal respiratory stridor causes noisy breathlessness of very short duration below 1 minute, and Kanistock's apnea results in breathlessness that is recurrent and clears each time in below 30 seconds. Orthopnea is suggestive of left ventricular failure or diaphragm paralysis, although it is also common in many chronic lung disease. Breathlessness during swimming is characteristic of bilateral diaphragm paralysis. Trypopnea refers to breathlessness when lying on one side as a result of ipsilateral pulmonary disease. Associated symptoms such as cough, hemoptysis, chest pain, wheeze, stridor, fever, loss of appetite and weight, and ankle swelling and the voice change. Wheeze may occur with pulmonary edema, pulmonary embolism, bronchiolitis, anaphylaxis, in addition to asthma and chronic obstructive pulmonary disease. Personal and family history of the chest disease, lifetime employment, hobbies, pets, travel, smoking, illicit drug use, medications, examination of the cardiovascular and respiratory system, observe the pattern and rate of breathing, assess for signs of respiratory distress, and look for paradoxical abdominal movement of if history suggests diaphragmatic paralysis. A useful bedside test to exercise the patient, e.g., stepping on and off a 15 or 20 centimeter block until their breathlessness occurs, and then measure oximetry immediately on stopping when the finger is still, and a fall in auto-saturation is expected with organic cause of dyspnea. Investigations. Initial investigations typically include resting oximetry, peak flow and spirometry, chest radiograph, and electrocardiogram. Further tests depend on clinical suspicion. Options include full pulmonary function tests with measurements of lung volumes lying and standing, gas transfer and flow volume loop, bronchial hyperresponsiveness or reversibility testing, maximal mouth or inspiratory sniff pressure, arterial blood gases with measurements of alveolar to arterial gradient, exercise oximetry, ventilation perfusion scanning, and computed tomographic pulmonary angiography, high resolution CT, blood tests, full blood count, and thyroid stimulating hormone, echocardiogram, exercise ECG, and the cardiac catheterizations. Cause of breathlessness grouped by speed of onset, instantaneous onset, such as pneumothorax and pulmonary embolism, acute, that's to say minutes to hours, onset include airway disease such as bronchial asthma, exacerbation of COPD, upper airway obstruction, parenchymal disease such as pneumonia, pulmonary edema, pulmonary hemorrhage, acute hypersensitivity pneumonitis, pulmonary vascular disease, cardiac disease, acute myocardial infarction, arrhythmia, valvular disease, tamponade, aortic dissection, metabolic acidosis, hyperventilation syndrome. Subacute onset, that's to say, onset of days, include the following many of the above, such as asthma, COPD, pneumonia, pulmonary edema, etc. In addition to pleural effusion, lobar collapse, acute interstitial pneumonia, superior vena cava obstruction, pulmonary vasculitis. Chronic occurs in months to years. Some of the above causes, such as COPD, asthma, diffuse parenchymal disease, including idiopathic pulmonary fibrosis, sarcoidosis, lymphangitis, carcinomatosis, pulmonary vascular disease, chronic thromboembolic disease, pulmonary hypertension, veno-occlusive disease, hypoventilation, such as chest wall deformity, neuromuscular weakness, and obesity hypoventilation syndrome or B's hypoventilation syndrome, anemia, and thyrotoxicosis. Specific situations in breathlessness. Cause of breathlessness with normal chest x-ray. Airway disease such as asthma, upper airway obstruction, and bronchiolitis. Pulmonary vascular disease such as pulmonary embolism, idiopathic pulmonary hypertension, infrapulmonary intrapulmonary shunt, early parenchymal disease such as sarcoid, interstitial pneumonias, infections, viral pneumocystitis jirovecii pneumonia, cardiac disease such as angina, arrhythmia, valvular disease, intracardiac shunt, neuromuscular weakness, metabolic acidosis, anemia, thyrotoxicosis, hyperventilation syndrome. Causes of episodic or intermittent breathlessness include asthma, pulmonary edema, angina, pulmonary embolism, hypersensitivity pneumonitis, vasculitis, hyperventilation syndrome. Distinguishing cardiac and respiratory causes of breathlessness. This can be difficult. Many of the clinical features of the left heart failure are non-specific and easily confused with respiratory disease, e.g., orthopnea or wheeze. In chronic cardiac failure, crackles on auscultation and radiological features of pulmonary edema may be absent, even when the pulmonary capillary wedge pressure is significantly raised due to adaptive changes from vascular remodeling. The presence of emphysema may also render crackles inaudible and lead to a typical chest X-ray appearance of pulmonary edema. Chronic left heart failure commonly leads to restrictive ventilatory defect and reduced gas transfer on pulmonary function tests and may also result in pulmonary hypertension. HRCT features of left heart failure include septal and peribronchovascular interstitial thickening, ground glass shadowing, pleural effusions, and cardiomegaly. Resting ECG is useful. In practice, a cardiac cause of breathlessness is unlikely in the setting of a completely normal ECG. Elevated brain natriuretic peptide BNB levels predict the likelihood of left ventricular impairment. Exercise ECG, echo, and cardiac catheterization may be required. Cardiac and respiratory disease can, of course, coexist.